Thank you for joining us today. If you are not an ATA member, please consider joining at https://atalink.org/become a member. The views expressed in this presentation are those of the speaker and do not reflect the official policy or position of the United States Air Force, the Department of Defense, the United States government, or the Airlift Tanker Association. Please take advantage of the question and answer feature in Teams to submit your questions anytime during the presentation. There is no need to wait until the end of the presentation portion to submit your questions. Also, make sure to like questions by clicking the thumbs up icon. That way we know what you want to hear about.
Good morning, ladies and gentlemen. I'm G.I. Tuck, the former Joint Staff Director of Logistics and now Deputy Chief of Supply, Production, and Distribution at Operation Warp Speed. And on behalf of Brigadier General Paul Friedrichs, the Joint Staff Surgeon General, we'd like to welcome you to this seminar as we discuss COVID-19 and the Joint Force response, how we saw ourselves, how we supported the national response through the lens of the National Defense Strategy, and how we kept up with military commitments across the globe in this new operational environment. We'd like to thank ATA for allowing us to host this seminar and the very important topic we bring to you today as we relook the last 9 months and the way ahead. We wanted you to know we didn't start with a blank slate when coronavirus first came to light. For instance, since 2006, we have had guidance on CDC modeling and burn rates for PPE expenditures in a pandemic. Although not to the scale we see today with COVID, we have contended with H1N1, SARS, Zika, MERS, and Ebola over the last 2 decades. The bullets on this slide are the outgrowth of specific planning guidance we have instituted, which includes a PlanORD and COVID pandemic campaign plan undertaken by the Joint Staff just this past summer. What we hope to convey with this chart is to show the relationships we already have with federal entities when dealing with homeland crises. Health and Human Services, along with the Center for Disease Control, was instrumental in providing DoD a framework for force health protection measures. The department mirrored this guidance in line with the National Security Council. FEMA stood up, and although we didn't quite execute the National Response Framework right out of the blocks, we did have guidance coming from the Vice President's COVID Task Force and the DoD COVID Task Force led by DepSecDef and the Vice Chairman to keep OSD and the Joint Staff laser focused on guidance to the force. We worked with Veterans Affairs, the State Department, and Uniformed Services University, among others, to ensure transparency and mutual support. This slide depicts support to U.S. NORTHCOM and FEMA. In order to provide 20 million N95 masks and 2,000 ventilators to the public, we needed to first determine the DoD PPE requirement and inventories across the services, our Guard and Reserve partners, and the combatant commands. We had a pretty good visibility through DHA what was in our 140 military treatment facilities, but not what was in operational stocks outside of these. Think AFRICOM, with a deployed force of 5,000 on the continent and no Role 3 medical treatment facility, or the Air Force's war readiness material in CONUS and OCONUS. How do you account for these? How do you know how much PPE and test equipment you need on hand in Central Command in order for them to prosecute their mission sets? We developed business rules, and those rules exist today in order to have 90 days of PPE supply to do the things you see pictured here last spring. Thanks to all the active, Guard, and Reserve forces who helped cities like New York, New Jersey, California, Illinois, Louisiana, Texas, and Florida during the first wave. Unfortunately, our work is not done yet. Focusing on DoD internal support in June and July, we needed to come up with a new model concept that looked out over the next 9 months on PPE expenditures, test regimens, test equipment, etc. This was done through OSD Health Affairs, the combatant commands, and their J4s and command surgeons. Last April and May, we also needed to come up with a way to operationally test the Joint Force with limited supply availability to ensure we could do our homeland defense and strategic missions, as well as keep the basic military training pipelines open for new recruits. The Joint Staff J3 came up with a way to prioritize through a tiered approach so that we could get right to the type of test we needed, high volume versus rapid, to the right test instrument, agnostic of which service owned it. For global transportation, kudos to Transcom for going after capability to transport COVID-positive patients, minimizing risk to other passengers and aircrew. They also developed ConOps to ensure commands who have OpCon of their theater assets to transport COVID patients could do so safely, mitigating risk. Another area of work was support to South Korea and Japan's fielded forces with testing protocols acceptable to those countries on rotator flights. Each topic on the procedures to minimize risk to service members and their PCSing families, which could then be exported to rotators throughout Europe, Africa, and the Middle East. Also support the command exercises and how to best support the Joint Forces participation and keep the medical risk down became a priority. For personal protective equipment, we could spend an entire session just on how we saw ourselves, how we were able to capture the right data, and use it to inform senior leadership on how DoD could support the national response. It all comes down to supporting the national defense strategy and mitigating risk if there's an operational gap. This is really a great news story that I hope you all have seen or heard about. Led by the folks at U.S. Transcom and briefed by Vice Admiral Mewborn to SecDef, DepSecDef, the chairman, vice chairman, and all the Joint Chiefs, combatant commands on COVID and commercial flying. What the study showed is how safe commercial air travel really is once you're on an airplane. Commercial aircraft have HEPA filtration systems, at least 2 per aircraft. Air is exchanged every 6 minutes or 10 times per hour. Air is pushed to the floor, what is kept by the airflow systems on commercial airplanes. And the result is no case or very low case among 100,000 passengers over this study were positive for corona. Military airplanes by review are not so good. For instance, cabin outflow valves are located in the cockpit of some of our aircraft where the airflow must move towards as it is being exchanged. The risk clearly is getting to an airplane from home or work, travel to an airport, once inside the airport, pre-boarding and boarding. And on the other end, it's exiting the aircraft, then inside the connecting or destination airport, and finally onward ground movement to destination. This is where the exposure risk increases. Pictured above is Admiral Mewborn getting a demo on how the data was captured. So where are we going? Vaccine partnership with companies like Moderna, Pfizer, AstraZeneca, Janssen through Johnson & Johnson, Sanofi, and Novavax, to name a few, and the work being done at warp speed along 6 lines of efforts: vaccines, therapeutics, diagnostics and testing, supply, production, and distribution, is absolutely crucial to turning the corner on COVID. Bringing on a vaccine, which usually takes 5 to 7 years to do, in less than 1 year, with 2 now in large clinical trials coming to completion towards Federal Drug Administration emergency use authorization, is incredible. The supply chain, think needles, syringes, diluent as part of the kits required to match vaccine production, all on CDC's or the developer's network of distribution providers to the point of need. All of this is happening now. Think of it this way. We are on the 20-yard line in the red zone, this coming from retired Lieutenant General Paul Ostrowski, Operation Warp Speed. Thank you all for being here at this seminar. Thanks again to ATA for hosting. We look forward to taking your comments and questions. And now back over to you.
Yeah, I'd like to open it up to GI Tuck for some comments. One I'd like to ask is, one of the issues that often occurs is that your study, you need to provide real world results back into it. Have you had time to do that, and where have you found that your studies needed to be bolstered?
Okay, hey everybody, it's GI. I hope you can see me. I've got Dr. Paul Friedrichs, Brigadier General Friedrichs, with me, and we'll try to answer these questions tag team as we go through the lineup today. You know, Tom, when you talk about studies just writ large, when you come across one like the one that you found that we briefed today on commercial aviation, and that gets briefed to the Secretary of Defense, and what it does is it gives us a sense, at least, that you know, the empirical evidence that's out there that supports commercial travel, at least being on the airplane, it's pretty sound. And the fact that Admiral Newborn and his team, along with the like DARPA and others that were on the slide, collaboration of folks to make that happen is it's pretty telling. And this was something that was really a good news story in the middle of you know, the coronavirus taking you know, a different turn after New York and the like. And starting to continue to rise, not necessarily in the second wave, but it gave us at least a little bit of, you know, of hope that we could actually see an opportunity to take a study like this and say, wow, okay, so we can at least attribute it not to being the airplane itself, and so it would at least make those of us who have to travel on this, just not only for military work, but for commercial travelers, to give them a sense that, hey, this is an industry that if we can figure out the front end and back end, then the airplane is a safe way to travel. It's not the reason for coronavirus spreading, in other words. And I'd offer Paul if he has another take on that, but that's where I saw it. That's where Admiral Newborn briefed it, and it was a good news story, and we certainly stand behind it.
So, General Tuck, thank you very much. And Tom, I would just add to what General Tuck said that one of the secrets of our success so far, I believe, was the decision to create the DoD COVID task force. You know, as General Tuck briefed, we had all sorts of plans on the shelf, but we really had planned for a regional response, and most of our national disasters or DISCA response had been regional. This quickly turned into a global whole of force challenge. And part of what the DoD task force has done for us is allowed us to gather from the COCOMs those urgent questions or problems that needed to be addressed. That cabin flow study directly came out of concerns from host nations transmitted to the COCOMs about, is it safe to have American forces coming into our country? That was an absolutely imperative operational question. And as General Tuck said, Transcom and DARPA did a fantastic job in leaning into that and quickly designing a study and executing it so that we could do more than just offer assurances, but actually do the scientific and analytic diligence needed to convince our allies and partners that it was indeed safe and appropriate. And that collaboration within DoD and then across the interagency, I think, has been one of the crucial success factors in the response to date. So thanks, General Tuck.
Okay, I have a question. Lieutenant Colonel Chris Keller, who starts off. General, congratulations on your retirement, and thank you for your continued service at Operation Warp Speed. I appreciate your comments on commercial aircraft cabin airflow study. Can you share any insights on TIS and how or what that capacity or capability is about?
Yeah, thanks, and I'll also let Doc jump in on this one too. The Transportation Isolation System came out years ago in collaboration with the Defense Threat Reduction Agency, U.S. Transportation Command, among others. There's also an effort being that was also done by the Department of State to field one on the commercial side, a system on the commercial side. And it came about, I think it was really aimed at trying to take a look at carrying infectious patients. along the lines of potentially Ebola and the like. And so that's how that capability came about. I was introduced to it as the J3 at U.S. Transportation Command in about the 2016 time frame. And since then, we have, a lot more than just the one or two that we started with. And I won't throw out a number over 20, but we ended up getting a lot of these things, and then we also migrated to something that is even better through the JUON that allowed us to get after a containerized system that we could put on an airplane just to tackle this particular disease. Paul, if you have any insights, because I think we both were there when Eric and others brought this to us, and we were able to do some flight tests on C-17s and C-130s at the time. Over.
Sir, you're exactly right, and I appreciate Colonel Keller's question because it really, again, highlights how quickly we learned, leveraged what we had in the inventory, and then realized we needed something better. So the TIS, as General Tuck described, was designed for the Ebola outbreak in partnership with a number of our key stakeholders, and especially the University of Nebraska. They have to give them a shout out. This was an exceptional public-private partnership that allowed us to field this capability as the Ebola outbreak was unfolding. As we rolled into this COVID outbreak, the COCOMs began looking at these folks with this novel virus. We had never seen it before. We had growing evidence from China and from Italy and then from New York City of really significant impact, but not enough data to understand exactly how much risk it posed to the force, to the aircrew, or to long-term contamination within the aircraft. And thanks, as General Tuck said, as a result of a JUON that Transcom submitted, based off of the concerns from the COCOMs, we quickly moved forward and developed a negative pressurized container system, which has now replaced the TIS, and that is what we're using. And we've moved hundreds of patients out of austere areas. It's a great step forward. The TIS was world-class at the time it was developed and continues to be an excellent asset for Ebola. The NPC, or negative pressurized container system, is an even bigger step forward and one that we'll be able to use in the future for man-made or naturally occurring biological threats that are affecting the force. So again, a great success story and a wonderful partnership between the logistics, transport, medical, industry, and academic communities to bring that forward so quickly and field it. Thank you.
Okay, I'd like to combine two questions that talk about a vaccine, one from retired Master Sergeant Carvata. Once a vaccine is released, how long do you think distribution with the military's help will take to reach the majority of the American public? And secondly, from Colonel Paul Murphy at the Naval War College, can you expand or predict the J4 Transcom AMC role in any forthcoming CONUS vaccine distribution plans or execution delivery?
Mic's off. Okay, my mic's back off. For the first one, for Gino Carvata, I think the plan is to have, you've got to have the vaccine and the kits that go with the vaccines, the needles, syringes. With the Pfizer product, it's called Diluent to help thaw it a little bit, but you've got to have the test kits all there so when the vaccines actually hit, when I say hit, they land where they're supposed to be at the point of need with healthcare workers and potentially older populations. It's really not supposed to take too long. So once the network delivers it, the goal is not to store it, but it's supposed to have an ability to put the vaccine into people. So it's actually going to be a matter of hours and days versus not days and weeks. So the majority of the people, though, it's a different kind of a question because of the amount of vaccine that will initially push out. In my second day here, that is really a very thoughtful discussion on how many we think we'll have by a certain time frame. So I won't necessarily talk about numbers because I'm not familiar with them. But what I will say is it's going to start off incrementally small, with a couple of companies initially, and as you get to the point where you can get 6 or more companies producing, that volume will increase over time. And so there'll have to be a prioritization by the immunization community. These are researchers and academics that will decide where these go, give that recommendation to the CDC, and then, you know, that distribution, it'll allow for a good distribution process. So initially to a smaller group of people until you get the volume where you need it to get it to the majority of the American public. That is the strategy that is being currently undertaken. With respect to, and then I'll turn it over to Paul here in just a second. But with respect to Paul Murphy, really great to have you on this one too, both of you, all of you. Right now, the distribution is going to be done in concert with the military. But when you're looking at the J4 Transcom AMC role with the distribution plans, it's being looked upon that the companies that are really good at doing this, like the influenza vaccine, for instance, they are going to be the ones that are going to be charged with delivering the product, working with this Warp Speed task force and with the CDC to make sure that the companies can get them from the manufacturer all the way to the point of need. Interestingly enough, I've been on some phone calls, and I would like to get reach out to Transcom and Air Mobility Command on a possibility of red teaming, how we could get the mobility machine plugged into this if it's necessary to do so. But that's right now, currently in my couple of days of being in the job, where we are. And I'll turn it over to Paul for his take.
Sir, thanks. And boy, those are truly billion-dollar questions right now. And I'll break it down from a couple of perspectives. So we've been working on this since May. And I want to foot stomp that because that's another incredible news story about the U.S. response here. As many of you know, it takes around 10 years to develop a new vaccine. Thanks to an investment of over $10 billion across the U.S. government in multiple different companies and industry partners, we are able to safely compress that by working in tandem, doing both studies and manufacturing in tandem rather than in series. And as General Tuck said, should have vaccine ready to distribute before the end of the year. To your question of how long will it take to distribute it, this is where I'd ask for the audience's help as you go out. There's a lot of mixed messaging on this, and as a doc, I'll tell you, I am more proud of this than almost anything that I've done in my career. This is unprecedented, the way the communities have come together to save lives by getting a safe and effective vaccine out there so quickly. Where we need people's help is to step back and recognize the value of these vaccines and encourage people to take them, because there's a lot of mixed messaging about vaccines out there right now. This investment is a tremendous success story, but it's only going to work if people agree to take the vaccine. From the standpoint of distributing it, as General Tuck described, there's several paths that'll work within the United States. Pfizer has committed to distributing their vaccine, and there's some reasons why they've chosen to do it that way. And then other industry partners are going to be responsible for distributing it within the continental United States. Our challenge is going to be, as we get to our afloat forces and our deployed forces and folks in the backwoods of different austere areas, how do we best either vaccinate them before they go there or get the vaccine to them? And as General Tuck said, some of that will depend on how quickly the manufacturers are able to scale up their production and how much we have available at one time. It'll also depend of the multiple vaccine candidates that we've invested in on which ones work best for which population. Typically in a flu season, for example, we'll find that one vaccine is particularly good for older Americans or for younger Americans, and we'll preferentially use it for that population. So there's a lot of known unknowns that we're going through with the very rigorously controlled safety and efficacy trials right now. But I would echo General Tuck's very confident statement that we have a great plan. It's constantly being revised as we get new information about which vaccines will be available, when, and who they best protect. So for folks who are frustrated that we can't answer all the questions right now, please know we're not holding information back. In fact, we're being very transparent about what we have, and also waiting for the scientific studies to answer some of these questions so that we do this as safely and effectively as possible.
All righty, from Anonymous, can you talk a little bit about the huge effort undertaken to get nearly all of the MAF military aircraft through airflow testing in Nebraska in only a handful of days?
Yeah, so I was aware of this huge effort to just understand airflow through the various mobility platforms. But my look at it was pretty cursory. I saw slides that had data on it. And so it was an impressive effort to get aircraft over to Nebraska to get tested in not only just a few days, but then to get that data out and kind of rank order which planes could actually move patients better or have a better propensity of moving COVID positive patients, and which ones would not. And it was ranked out 1 to N. And so, yeah, hats off to the crews and maintainers and all the test folks and everyone who was connected to that particular effort. But my knowledge of anything more than that is just then taking that data and then having a better understanding of how you could use it in terms of where you wanted to accept risk when it came to putting patients on what kinds of platforms. Paul, I don't know if you're familiar with the study more than I am, but that's really my level of the detail in that particular one.
Sir, I'd echo your point. There's another tremendous effort in quickly answering an important question. And again, it's interesting that they highlighted the key public-private partnership with the University of Nebraska and with our industry partners to be able to do that so quickly and so effectively. We've got to maintain those linkages with the academic community and the research community, because in the future, whether it's a new novel virus or a man-made biological threat, we're going to go through some of the same iterations as we respond and figure out how best to operate in that next pandemic, whatever it may be and whenever it may be.
And this from Shane Hirschman. Congratulations on the product. If we look at indications and warnings, do you have any suggestions for prescriptive and predictive analytics using data and indications for how we can use those indications for future threats against the DoD?
Yeah, this one I'll start with Paul, because he gives a briefing every day to DepSecDef and the secretary on analytical data on how this particular pandemic is moving across the military force, and he compares that data against what's happening on the outside so that we can hopefully see ourselves in some trajectory down the road. But Paul, not to put you on the spot, but because you give that briefing, you're so good at it, I'll give you a first crack at this one.
Sir, thanks very much, and thanks for the question. So I think it'll be important for us to look at this through several lenses. The first one is risk to the force, and that's where having robust surveillance capabilities to identify when we're seeing new outbreaks, whether it's within the military population, which we hope we are not the leading source of an outbreak, or more likely, as in this case, occurring in another country's civilian population. Now, we talk a lot about allies and partners, but the DoD for years has partnered with research labs and surveillance labs in Africa, Asia, and South America. We've got to maintain those capabilities because we don't know where the next outbreak or pandemic will occur, or God forbid, a man-made biological threat will be released. So having that surveillance capability is an important part of the indications and warnings that we look for to see that we're seeing an increase in the number of respiratory illnesses or an increase in the number of people going into the hospital. And then within DoD, we track that just as closely so that we understand the risk to the force and to the families. And this gets not just down to the active duty force, but it's got to be the reserve component as well, because we've relied heavily on them, as many of you are well aware, throughout this response. We've identified that we need better ways to track what happens to our service members, and especially reserve component service members who are out in the civilian healthcare sector. And our new electronic health record that we're in the process of deploying across DoD and eventually across the VA will help tremendously with that, because it allows better data sharing across healthcare platforms. So that looks at, indications and warnings that more people are getting sick. We also need indications and warnings that look at the logistics system, and this is where the partnership with General Tuck was, at times incredibly challenging, but always a great pleasure to work with him, because what we found very quickly was we need a better way to be able to see the consumption of medical supplies or other supplies related to an outbreak, aggregate that data, understand how that consumption rate compares to resupply rates, and then present that to the senior leaders to help inform decisions about how much support we need within a particular COCOM or even down to an installation level, and how much support we can provide to the interagency. So looking at that supply chain set of indications and warnings is equally important going forward. And then the third lens is, for us in the military, what's the impact on readiness? So we're 9-10 months into this pandemic, and we have had a heck of a lot of people working from home. We've canceled exercises, we have done all sorts of things. Again, I'm incredibly proud of the fact that we have continued to defend the United States of America and accomplish our key missions in spite of the pandemic. But there are things that we've not done, and having those indications and warnings about the impact on readiness, whether it's delays in a depot being able to turn repairs on a tank, or delays in folks being able to get to training because of travel restrictions, those indications and warnings are also really important for us to look at and pull together into a holistic understanding of the impact of a pandemic or a man-made threat as we go forward over time. Hope that was helpful. Thanks, General Tuck.
Thanks, Paul.
And another one from Anonymous. This new information regarding air cabin disinfection is fascinating. And as a COVID response member at my base, would this possibly negate the need for the 14-day ROM upon arrival, especially if it could possibly neutralize the airborne effectiveness of the virus?
So that is really an amazing question, because if you could have the entire clean corridor as it's described, from the time you left your house that you know that you have taken a test and you're negative, and that, just how that test goes, depending on what that test looks for, you could be asymptomatic and still come out negative, or asymptomatic and still be positive. But the point I'm trying to make is that once you leave home to once you get to your destination, if that entire corridor could be as good as the study of that aircraft, then the answer would be yes. But because there's so much contact with just the human population, from getting from your home through the transportation network, ground transportation, to an airport, the risk just becomes a little bit higher. And so negating the need for 14-day ROM upon arrival will be a difficult one until we get the vaccine. Now, there are some other methodologies that when I was leaving the Joint Staff, if you could get to an oral test, for instance, if you can get to other rapid ways to bring down the 14-day ROM, but the test just was a really good way to show that disinfecting an aircraft has a good chance of COVID not happening. It's just the rest of that part of connecting to the airplane that becomes very problematic. And Paul, I'll turn it over to you because I think you've got a comment.
General Tuck, thanks, and I agree, that's a great question. So if we could live in homes that turned over the air in the home 10 times an hour and had 2 HEPA filters in them, and our cars had that, and our restaurants and our workplaces had that, we'd be in great shape. because then you're really reducing at least the airborne transmission. Unfortunately, as we found with this virus, it's spread and shared in different ways. And so what we're doing in the aircraft and what DARPA and Transcom demonstrated is very important as a risk mitigation strategy, but not sufficient. The answer that many people hate for me to give, but it's the truth, is the most important mitigation step continues to be those public health measures that your mom taught you when you were really little. Cover your mouth when you sneeze. Don't touch people if you're sick. Stay home if you're sick. Don't go out around other people if you're sick. Those are all really important. Until we're able to get to the point, as General Tuck said, that we have a high percent of the population, probably between 60 to 80% of the population who are vaccinated, we're going to need to continue with those basic public health measures going forward. I think that the attractive part of that aircraft study is it shows that if we can combine public health measures before you get on the airplane and after you get on the airplane, we can reduce the risk of being infected during travel. As General Tuck also mentioned, the next part is, since we don't think we can eliminate it, and statistically we've not been able to model a way to eliminate it, what are the other things that can reduce the length of that ROM period? And there's some great pilot studies going on both within DoD and in the civilian sector, looking at a combination of testing and shorter ROM. We did this in the early days at our basic training bases, where we said, if you bring everybody in, test them on arrival, and then keep them in ROM for a varying length of time, test them periodically during their ROM, what's the right number of days to keep them in ROM? Interestingly, our data initially also suggested 14 days was about right. As we gather more data and we get better tests, these rapid antigen tests, and some of the other new capabilities that are coming out, we think that there may be ways to reduce the ROM in combination with serial testing. But what we want to make darn sure of is that we don't increase risk to the force or to the mission by decreasing the ROM before we understand what those trade-offs are. So a lot of work being done on that area right now, both within DoD and across the United States as a whole. I think we're going to see the fruit of those efforts playing out in the next few months here. Thank you.
A question from Anonymous. In relationship to the JUON, the patient movement number is extremely high in relation to patients moved in a short time frame. The NPC has a great capability, but do we have the planes to even move that large number in the inventory?
Okay, so the JUON was an outgrowth of not having enough capability to move patients. If you take a look at the CDC planning factors early on, when we were first trying to understand how many people that we might be responsible for and moving that were COVID positive, the numbers were much, much higher than the percentages nationally of what we saw. And so we were gearing up for a much larger number that the CDC had actually used since way back in 2006, when the pandemic first when we started looking at pandemics and formulas for how many people we could plan for getting sick. The numbers were really high. But what actually panned out over time was the numbers across the nation, and then even lower in our military, because our population is younger and for other various reasons, we did not get as sick. And so your question's an important one, because had we scaled and had to move back, for instance, people from Central Command or people from Indo-PACOM, the inventory of aircraft that we have to move patients in the numbers that could fit in some of these things like the TIS and the NPC, we would not have had enough airplanes in the inventory to do that. And so we were looking at types of strategies that we might be able to employ to be able to either move patients or get patients isolated and still get them the medical coverage that they needed at the locations that they were at. And so that's really where, through learning about this pandemic, learning about how the cells replicate, learning about the fact that it didn't, the math was different than what was planned for and what actually happened. We were able to move patients in a way that was safe. But the question's a really good one, because had the numbers planned out to where the planning factors are aimed at, we would not have had the airplanes to do that. Paul, I don't know if you have any more to add to that.
Sir, I think you're exactly right. And you and I worked together on the global patient movement system when you were at AMC and I was at Transcom. And that this is that trade-off that we look at whenever there's a biological threat to the force. How much do you move? In this case, as General Tuck said, we actually changed our policy and agreed to move these patients, because often we'll say if there's a chemical or a biological threat, we'll treat people in place because the logistics and the medical support required to move them is so great. This has been this pandemic has been a terrible challenge in many ways, but Transcom and AMC and many others have done an outstanding job of coming up with risk mitigation measures and proving that we could safely move these patients without increasing risk to the crew or to the aircraft, or frankly to the rest of the JLET. I mean, the rest of the military operations have continued while we did these patient movements. And we've not had a single crew member or AirVac member who became infected as a result of these moves. So the assemblages that we built with the TIS and the NPC worked very well for this. That's not something that we can count on happening every time. And this goes back to that excellent earlier question about indications and warnings and understanding as a pandemic is unfolding the characteristics of the threat to the force. In this case, as bad as this one is, we were able to mitigate that risk and move those who needed to be moved without impacting the JLENT significantly or exceeding our capacity. But the next pandemic is likely to be very different than this one. So we'll have to reassess that every single time. Thank you.
And anonymous, sir, has consideration been given to getting back to normal operations and 100% office manning? Are we going to continue the 10% increase every 2 weeks or until a vaccine is available?
Okay, so for this one, what's really important to understand is that there are force health protection measures that are provided by the Department of Defense that give guidance as to how we're going to man based on how the country's opening up, based on where your base is sitting, based on the environment that you're living in. So there's all of these caveats or qualifiers, if you will. When the Pentagon was given an opportunity to take a look at the matrix that we were given, the J4 could have brought back enough people that would have exceeded the 6-foot spacing that we needed in our cubicles. So what we ended up doing was, yes, we could have complied with the force health protection and bringing back a lot more people, but what we did was we maintained the spacing that was viable to keep our spaces safe. So the workforce that we brought back didn't even top the 50% of what we had, because we were on a big floor with systems furniture, not office spaces, and so that's how we chose to do that. And I know that a lot of you are look at your own installations and manage risks the way that appropriately, the way that you do, keeping in with the force health protection guidance that specifically talks about how we open up our bases, how we open up our workspaces, how we open up, getting back towards that 100% alluded to in the question. And so I think what you're going to find is that as long as there is coronavirus cases that are showing up, and we do the measures that General Friedrich had mentioned earlier, in terms of keeping as clean as you can be, this will happen, I think, until we have a vaccine, or until we can turn the tide on COVID with maybe other measures that are out there that can help do it. But that is a really good question that was asked and posited. And I'll turn it over to Paul if he's got anything else he'd like to add.
Hey, sir, thanks very much. And I agree, it's a great question. And, I heard a similar discussion just a couple of days ago But the gist of the discussion was, at least within DoD, we continue to trust commanders to be commanders and look at the threat to their base population or their installation or their unit in that environment. What do I mean by that? You know, Colorado had snow at the same time that the Gulf Coast was preparing for a hurricane. California was dealing with wildfires. Commanders make threat-informed decisions every day about what the right number of people are to come into work and what the right way is to execute their mission. And what we've tried very hard to do as we crafted policy in DoD was to continue to inform and empower commanders so they could make those right decisions based on the conditions at that moment in time at their installation or for their unit. Now, the one size fits all that we've learned really doesn't work well. If we go back to March, New York was getting creamed by the virus, but most of the rest of the country was seeing a much lower impact. Today, we've got widespread transmission across the country, but we're not seeing the same levels of hospitalization, hopefully, that we saw in New York. We want to make sure that we don't tie the hands of commanders or leaders, but help them understand the risks. And as General Tuck said, if they can mitigate them through the public health measures, that's great. If they can't, and folks can work from home, then they should continue to do so until we have been able to turn the tide on community transmission and get it back down to a much lower level. Thank you.
Oh, and a related note from Anonymous, and I apologize to them because I'm going to paraphrase their question. At my base and in my community, it feels as though the populace has largely accepted that COVID-19 is either not a threat, is greatly exaggerated, or a new fact of life. It seems as though we have forgotten how serious this is. I understand that a long-term shutdown isn't viable, but is there anything that can be done to keep service members safe while maintaining an acceptable degree of operational capability in the face of this much greater infection rate? Is there anything you would recommend that can be done to reinforce the idea that this is something to be taken seriously?
Yeah, we're both gonna take a shot at answering this one because this is a very, very important question that we're finding. I'll start, I'll pass it over to Paul, and then I'm gonna ask Paul to hand it back to me because I'd like to close on this question even more so. And I wanna give him time since he's got the medical expertise to part of the question that you're asking. When you take a look at where we were back in March, and I'm going to just use your question since you brought it up, we shut down the government, and we looked at all of the metrics that were coming into the Joint Staff through Johns Hopkins, FEMA, all kinds of other agencies out there. You could see that, you know, once New York's was continuing up and it came down, we were actually in a pretty, I wouldn't say a decent spot, but at least the trajectory, the rise over run was not exponential. Yes, we were still having daily rise in COVID cases. The morbidity rate was coming down. Hospitalization rates that we saw, if you just take a look at ventilators and how many people were on them versus in the May timeframe when the hospital utilization for vents and bed spaces, tracking all of this data was probably at a lower point than where we're finding it today. I think people were taking it seriously. I think people are taking it serious today, but there are some segments of our society, I say that may not be, and it can be because of things that you see happening in the news. When you have communities that are trying their very best to survive in an economy and not have their business go under, how can they best support their workforce and their businesses, and also be mindful that there's a pandemic out there. I would say how you behave on base is how you should behave off base, and it's just like if no one's looking. I mean, if you put that mask on every time that you get out of your house and wear it till you're allowed to take it off, and show others that you're doing it, and leaders out there are showing that they're doing that, I think it makes the case for the youngest of our folks who aren't seeing the mixed messaging that might show, and they're paying attention to it. And I'm not suggesting that we might need to lead with a very disciplinary approach, But we are focused on the fact that we don't have a vaccine. And some of the ways that we can mitigate this is make sure that we have the social distancing rules. We're mindful of the health protection measures that are out there. The commanders out there ought to be leading and not allowing people to go to places potentially that are not in compliance with coronavirus, so that when it comes to mission execution, we have the human resource available to be able to do that. I'm from the state of Hawaii. They had a very low run for a very long time, and then they had a spike, and their spike is not like maybe other states in terms of the numbers, but it was enough for them to catch their attention, to shut a lot of things down, and to come up with a 14-day quarantine and limit passengers flying in. And so my sense is that we've got to pay attention to what we're seeing, and we have to make sure that people are complying with with the policies that we have in place, because it is about national security. It is about maintaining that discipline. So if we can actually move our mission to support the national defense strategy in the way that we're intending to, we have the workforce that can seriously do that. Paul, I'll turn it back over to you, and I've got a couple more thoughts I want to close. I just didn't want to gobble up all your time.
Hey, sir, thanks very much, and thanks to whoever asked that question. So first, I'd just reiterate what we've talked about several times already. Those basic public health measures have worked for centuries. We've known now, going back a couple of hundred years, what is really effective with an infectious outbreak like this. And so that's nothing new. The opportunity that I think we have, and I'll take my doctor's hat off and put my officer hat on or my airman hat on for just a second and say, we've earned the trust of the American people. For 200 years, they've looked to the military as some of the best of our nation. This is our chance yet again to show them what right looks like, not to question authority. That's not part of our ethos to say, well, I'm not going to do it because it impacts my life. Things impact our life all the time. We as a organization volunteer to serve the needs of our nation. And this is one more opportunity for us to do it by embracing those things that are, yes, tough to do, but we all know are the right things to do. Just like we embrace the need when we put our uniforms on and we deploy. We embrace the need to leave our families behind when our country says they need us. This is one more opportunity for us to embrace our role as leaders and those who serve our country by showing what right looks like. And if people aren't taking it seriously, it's not our job to go out there and be the healthcare police, but it is our job to do the right thing. And when they look around, they say, isn't that guy in the Air Force over there? Isn't that guy in the Navy over there? Yeah, notice he's got his mask on. Notice he's actually doing all that stuff they're talking about on TV. That's how we're going to help turn the tide with all of this. This is about what we do as airmen, as soldiers, Marines, sailors, whatever role you play in the military. It's not just what you do in the confines of your home. It's how you participate in your community. And we've got a 200+ track record of being leaders, not just in defending our community in conflict, but in being those role models in the community every single day of the year. So don't miss that opportunity to help our country because you think it's a little inconvenient. Help show that we've continued to earn the respect and the trust of the American public because we're doing the right thing, whether we're in Africa, we're in Asia, or we're back home in Akron, Ohio, because that's what we do every single day that we wear this uniform. Sorry if that sounds a little passionate, but I tell you what, if ever the country needed a role model, needed the military to continue to show why we deserve the trust of the American public, this is one of those times. Help us keep that trust by doing the right thing. We'll get out of this. We always do get out of a pandemic. We can help get out of it faster by acting the way we know we should. Thanks, General Tuck.
Okay, so just really dissecting your question. Thanks, Paul, for doing that. When it comes to your base and the fact that, and your community and the fact that people might not be taking it seriously, And we could overlay that on a lot of cities today that you could actually just, project that onto. We've got to change the messaging there. We've got to actually change and show the data and let people see the data. Whether they accept it or believe it, at least they have to be shown it, that we're not even close to being out of the woods. And so until you change people's minds about something, it will go greatly exaggerated or be looked at as something that is not a threat. And it is a threat. And as long as the leadership and senior NCOs are talking about it and constantly talking about it and addressing it, I think that's a very good first step. And what can be done to keep service members safe? Each one of you can pick up your own mantle and say, you know what, I'm not taking my family of 4 to go to X, Y, and Z place today because it's just not the day that we ought to be going out. There are some decisions that you can make that others can make that can help. Now, I'm not talking about commanders limiting movement, but at least advising on what what is acceptable within the force health protection measures that are out there and what are not. And then as people see things, just as if someone needed a haircut, you've got to be able to have the courage to approach someone and say, hey, you need to put the mask on. This is a very serious time. And so I know, and so that's why I really wanted to come back and answer this one. So I think there are some things that we can be doing. And then for the second part of your question, what would I recommend to reinforce the idea that something like this has to be taken seriously by those who seem to disregard it? It is almost being so nosy and in your face and telling stories about people who know people who are sick who are no longer here. Because I'll tell you, I have friends and family members that I know of that are sick, have been sick, and not here. And as we continue to talk about, this, it can't be looked at the lens of I'm claustrophobic, I've got to get out, I've been doing this for so long. It's numbing. Yes, it is numbing, but you just have to pay attention to the data out there. What was asked earlier about indications and warnings. If you pay attention to the indications and warnings and take them seriously, no base and community would be feeling the effects of what brought this question on. And unfortunately, in a country as free as ours, and people can make decisions all they want to, it's impactful for us. So if you can stay clear of areas where people are not adhering to safe social distancing and safe practices when it comes to COVID-19, that's part of the best solution, is to not be around where those areas are. Okay, Tom, I'll turn it back over to you, and we cede our time back to you, the moderator.
Gentlemen, on behalf of the Airlift Tanker Association, I'd like to thank you both for taking time out of your very busy schedules to join us here online.
Thank you for joining us today. If you are not an ATA member, please consider joining at https://atalink.org/become a member.